Hi, this is Barbara Howard. I'm here today talking about functional behavioral assessment, which is an important thing for pediatricians to understand. First, I have to tell you that my conflict of interest is as one of the creators of Chattis, although we're not talking about Chattis today. Today, we're going to talk about a case of a 14-year-old boy with autism and use that as an example of the importance of functional behavioral assessment. So, Matt is a 14-year-old boy with moderately severe autism who is brought in by his parents because he's been attacking his mother and his teachers intermittently at school and at home. This is a child who only speaks in phrases, and during the visit, although he responded to me in phrases and single words, he rocked a lot during the visit and appeared mildly agitated. So when you think about a kid like this, you have many things to consider. Certainly his autism is a major factor, but we have an immediate kind of emergency because the mother is getting injured and so are the teachers, and he is on the verge of being either taken out of his school setting, or the mother actually was in tears on the phone wondering if she needed to actually institutionalize him. So this is a serious problem. So what do you do in a case like this? Well, the most important thing to do is to try to figure out more about the behavior and what sets it off. And there's actually a name for this kind of an intervention. So the simplest version of this is something everybody probably recognizes from Psychology 101, which is to think about the A's, the B's, and the C's of behavior. But I've added to this mnemonic the G, so I'm going to explain that to you now. So the A stands for antecedents. What is going on before a behavior occurs that's a problem behavior? And that might include things that are called setting events. So it might be something that happened that morning. Is this a day the child had trouble getting out of bed or didn't get breakfast or was sleeping in a different location than usual? And then what seems to have set it off? Second, the behavior itself. What exactly does the child do? In this case, Matt actually was holding his head and moaning and then pacing back and forth and finally coming over and pinching his mother and then beginning to push her. At school, he would start making noises and then began coming at the teacher and throwing over chairs. So those were the behaviors that were the problem. And then thinking about the consequence, this includes, let me mention something more about behavior, and that is the B can also stand for beliefs. So we don't have any insight right now into the beliefs of this particular child, but in many cases you can ask children who are more typically developing more about what did they think was going to happen? What are some of the things that were in their minds, not just in the behavior? And then the consequence is what resulted for the child and for the parent as a result of this behavior. And that might include things that would reinforce the behavior or things about how they would feel. So we know that this child would be agitated and aggressive for about 10 minutes and then would stop. So we don't know exactly how he was feeling about it. We certainly do know that the mother would be very upset and would be in tears herself and would also get angry. But the other piece that's usually not taught so much in Psych 101 is what might be the G or the gap. What is the gap in skills or the things that set up this episode? So thinking about this child, certainly his autism results in all kinds of gaps in skills, including a failure to be able to communicate with words effectively what the source of his distress might be. He had other gaps in skills as well. So the gap in skills at school included practically all of his schoolwork because he is actually in a general education classroom, but he does have a one-on-one aide, but he's not able to do any of the work in school. But what could the gaps in skills be at home? So when asking about the context of these episodes, it turns out that he would be just relatively happily playing his video games or doing other activities that he normally does for recreation at home when one of these would come on. So it wasn't clear that something had set him off. When asked about the video games, the mother reported these were his regular ones. He watches over and over and over and over and over again. They're not new ones or ones that are particularly upsetting, or ones where he has to go to a certain level of achievement. That's pretty common in kids with, even typically developing kids when they're frustrated by video games these days. That's something to think about. So that's a simple kind of way of looking at this behavior, but as you can see, it didn't solve the problem in this case. So thinking about how to analyze behaviors more thoroughly might include doing something called a functional behavioral assessment. That's what the schools call it. The original name for this in the field of psychology is functional behavioral analysis. So you're analyzing the behavior. So what exactly is a functional behavioral assessment? Well, first of all, it's a thorough description of the behavior, ideally from multiple data sources. So in his case, we were asking information from his mother and also from his teacher. We couldn't really ask him anything about it because he wasn't able to describe anything. And then to describe the behavior in detail with regard to what settings it's occurring in, how often this is occurring, how intense the behavior is, and how long it lasts. So in his case, it was happening during recreation at home, but also in school during classwork. It's only about every 2 weeks, but it was very intense, even causing injury, and would last about 10 or 15 minutes. And then you want to find out about previous interventions. What have they tried so far? So at school, they've tried sending him out to timeout. At home, similarly, the mother has sent him to his room, which is where he would normally go for timeout if he was having a behavior that was unacceptable. She also tried asking him what was going on. She had tried giving him something to eat, thinking maybe he was hungry, and those are the things she had tried so far. Now, if this is a behavior at school, you want to know what the educational impact is as well. In this case, of course, he was completely unavailable for instruction when he was having one of those things, one of those episodes. And in addition to that, he was disrupting the rest of the class for everybody else, so it was having impact on the whole school setting. So in the course of functional behavioral assessment, what you're looking for is what is the function of the behavior itself. And what we mean by that is what purpose might it serve, looking for the identification of important, controllable, and causal and/or causal functional relationships that are applicable to this specific target behavior for this patient. Usually you should think multimodally because each behavior typically has multiple causes that might contribute differentially to the expression of that behavior. So thinking about the kinds of functions, you want to look at both contexts, such as what is the function for the child, what is the context of the school, peers, and family, and what category might the functions fall into. Would these be things that are proximal, distal, like stimuli from a distance? Is it a physiological problem, or is it some kind of intrapsychic problem, meaning a thought process that's going on? It's important to realize that there are two basic functions to look at in a functional behavioral analysis. And if you look at the top there, you see the problem behavior could be oriented towards either obtaining something, such as some kind of sensory stimulation. Things are often blamed on that for kids with autism, and sometimes overly so, I think. Is it some kind of social thing that they're trying to get? In the case of a child, a typically developing child who might be clowning around in school when they don't know how to do their math problems, they get some social recognition for clowning around, and they also get out of something. In that case, get out of doing math. So it can be to obtain something or to escape something. Now, as you notice, escaping things can have some of the same results. They could escape tangibly if you get out of math class by acting up and you're bad in math. The benefit to you, the reinforcement for you, is not having to do your math work and not being mortified in front of your peer group, which is social. In the case of this child, whether attacking his parent is something that sort of gives him a sense of arousal that he appreciates. That's what we didn't know yet. And, of course, the social impact can be with regard to adults or with regard to the peer group. So here's a list of some things that are considered typical areas to look at when you're doing a functional behavioral assessment. One has to do with affective regulation or emotional reactivity. Is the function of the behavior to help regulate yourself, or it could be to arouse the child, to arouse themselves, to feel some satisfaction from getting emotions out there into the world? Is it related to some cognitive process, which might even be a cognitive distortion? So an example of that might be a child who, when there is a fire alarm test that goes off in the school, now that has sensory aspects, especially for kids on the autism spectrum, but also it may make a child who has limited understanding cognitive distortions about that means that maybe the school's going to burn down and they're going to be burned up. That would be a cognitive distortion that would contribute to a behavior problem in that case. Is there some reinforcement, like a child getting out of math class, or in this child's case, getting a snack, which the mother was using as some way of trying to deal with this aggressive behavior? She'd be giving him a snack. Is it something that is being modeled by other children? So is this child trying to fit in with peers by doing something that he sees other peers doing? This is sometimes a problem in children who are in what's called a behaviorally and emotionally disturbed classroom, where there are lots of models of behaviors that really wouldn't be considered typical, normal, okay behavior, where people are rocking or biting themselves or moaning or throwing things. He may be modeling after somebody else. Now, this particular child actually is only in general education classes, so he hasn't had those models for himself, and he doesn't have models for aggressive behavior at home either. In fact, he's generally not an aggressive child. Are there family issues that are setting this off? Now, this is more in the category of precipitants for some kids, where family stressors show up with a behavior in another setting. But the other thing is that sometimes children will act up at home in order to get the parents to stop arguing with each other and take on the child's behavior instead. So it can be a way of diverting the family. So that would be an example of a family issue. How about physiological or constitutional factors? Well, in this case, this child was putting his hands to his head and moaning, which made me think about whether he may be having a headache. And one of the things you no doubt know about children with autism, particularly children who are not very verbal, is that they can have exactly the same medical problems as anybody else. And 14-year-olds have plenty of those of their own. And in fact, there is a family history of migraine. And so when we looked at this more closely, it looked as though he was actually having a headache. And so the way we figured this out is him holding his head. And when the mother was more specific in asking him, did his head hurt? And one of the interventions we made as part of this process was to give him some ibuprofen, that actually these episodes went away. And the mother began to recognize the signals of this headache earlier and earlier in the sequence. So thinking about children on the autism spectrum, some of the things that can set them off is any kind of pain. And so even though they have different responses to pain than typically developing children, they, of course, can have headaches, toothaches, ear aches, stomach aches, constipation. They can have, those are some of the more common ones that can make a child with autism try to complain of pain, but do so in a behaviorally dysfunctional way. In his case, he was unable to communicate his need for some help with his headache, but he was seeking the help from the adults, and that's why the parent and the teacher were getting the behavior directed at them rather than somebody in the classroom. He was communicating a need. Now, in a classroom setting, you also want to think about whether the function has something to do with the curriculum or the instruction. If this child may, in fact, have a learning disability that's making them act up because they can't cope with the frustration of the work that's being asked of them. So that fits in with most school-type behaviors is to be thinking about which class is it in, what subject are they teaching, are they being asked to stand up in front of the room, is this a form of instruction that they can't absorb or can't cope with. So the steps to carrying out a functional behavioral assessment include developing a hypothesis, make a guess, what is this about, and then to test that hypothesis by conducting little experiments with this individual child to find out what might help head these off. So in this case, mother already experimented with food and with timeout, but when we experimented with some medicine for migraine, he actually did much better. Now, in many cases, what you want to do is figure out a new replacement activity. That's called a positive behavior intervention, to figure out what activity could they do instead of attacking the parent or the teacher. So in his case, the parent and the school, by recognizing that he was getting headaches, actually would start to say to him, does your head hurt? Let's get you some medicine. And that by having him hold his head at the communication, that helped him to be able to signal at the onset of the headache instead of when he was in extreme pain. So once you figure out some replacement activities, then this gets put into a behavioral intervention plan at school or at home, and then you implement the plan and see if it works. So that's the sequence of steps. Now, I want to point out to you that that under the IDEA legislation, Individuals with Disabilities Education Act in the United States, a functional behavioral assessment is required for students who have disabilities or between ages 3 and 21 within 10 days if they are suspended or removed from their regular setting to an interim alternative educational setting. The law says you have to do a functional behavioral assessment. So now, in many cases, the school is not suspending the children for this, but they are struggling with these behaviors. So one of the impacts of having this legislation is that there are people in the school who know how to do functional behavioral assessments with students. So one of the things that can be very helpful for us as primary care doctors is when you hear about a child who's having a new, perhaps, or chronic or recurrent behavior, to actually request that the school carry out a functional behavioral assessment to help figure out what these precipitating events are and to try some of those experiments to manage it in order to allow the child to stay in their least restrictive environment. So those are some thoughts about functional behavioral assessments. About you, Dr. Sterner, do you have any cases or comments about the concepts of functional behavioral assessment?
Well, you talked about gaps in behavior, and that's an important point. I wonder if you could elaborate on that, and that may show up with the kids who are more in the typical range, and like ADHD or things like that.
Why don't you go ahead and comment on that?
Well, I think that I think Dr. Ross Green talks about that as a way of understanding kids' behavior, that parents already do a functional behavior analysis, and they have a faulty functional behavior analysis is the problem. They said, he's just trying to get attention, or he's just had some kind of moral view. And so I think that one, we don't talk about the parents' functional behavior analysis, but they're doing it, and I think your paradigm might be helpful for them because you've got a kid who's looking typical and acts typical, but maybe having a tantrum because you were talking about they're playing with their video game, and it's time to do something boring relatively for them, like come to dinner or brush their teeth, and they have a fit. And so one other aspect I'm only saying is that to ask the parents for their functional behavior, what do you think is going on? What's causing it? and then they do have hypotheses, and then they do interventions or based on their hypothesis, like scold them and then introducing the gaps. Well, that he's a kid who may get so absorbed in what he's doing that he maybe didn't even hear you the first few times until you start screaming at him. And maybe it's something that's called a transition problem, something like that. That's part of this invisible handicap. So anyhow, so it's a different way of thinking about it. It occurred to me.
Right. I think that's really important, and we sometimes talk about parents projecting things onto their child, such as the behavior of their spouse, which they don't like, and then they attack the kid for a similar kind of behavior, or what I think you actually call prejudiced parent syndrome, where the parent is prone to interpret a behavior in a way that not only is not accurate, but also results in their behavior not being useful to them. This happens even in little tiny babies. So, for example, babies who are crying, first of all, we think babies who are crying need something, but some parents think the babies who are crying are spoiled. And so as a result of that interpretation, that their decision is, if the baby is spoiled, we're going to either punish the baby or ignore the baby's pleas for communication. So it is important to think about the parents and ideas about that and ask them, just as you said, what do you think this behavior means? And that is often sort of missing from a discussion, but I think that the functional behavioral analysis can help with the meaning of the behavior in the cognitive distortions, for example. That helps you say, what is it you think the child is thinking? But what you're pointing out is maybe you should think about, what is it the parent thinks the child is thinking?
Right.
Without knowing that for sure.
That they're just, thrown to thinking, doing automatic functional behavioral analyses, and we don't have a good way of sort of reframing what they're saying that in terms of these components. Maybe we need to teach parents how to do something like this. Well, and particularly think about the gaps in gaps in functioning as a cause for behavior rather than moral inadequacies.
Right. So let's see. I think that knowing that there's that there are professionals who are trained in functional behavioral assessment is really important. Often it's the psychologists who are have the best training and will come in and do a classroom observation of the child in order to figure these things out. Now, the book that Dr. Sterner made a reference to is called The Explosive Child. Ross Greene, it's Greene, also has a book for teachers which goes over some of these same things. So I think it's useful to think about what the gap in skills might be. So in this child, it was pretty obvious. In a child who's not doing well in math and acts up in math class, that could be pretty obvious too once you think about it. But sometimes things are more subtle. For example, there are children who have some obsessions. They may not have a full OCD, but they may have a high need for orderliness, and they're easily thrown and unable to handle a change in schedule or a change in even the way the furniture is organized in the house or the classroom. Now, there's an overlap with the autism spectrum in these cases, but for them, the gap in skills is the ability to be flexible. And that gives you something specific to work on, by the way, in the treatment of those children, to work on flexibility. That's where I might pull out one of my favorite interventions, which is giving children marks on their hand, which result in a reward at the end of the day. And you give the marks for little bits of flexibility, along with saying to the child, good job being a little more flexible. So in other words, you're trying to teach them to recognize the times when their gap in skills is acting up, lack of flexibility. Children who are anxious, sometimes they have an inability to deal with for example, a request for them to go up to the board and write something on the board, not because they can't write, not because they can't walk, but because they're anxious and that they're too shy to be able to do that. And so giving them some other way to present their work while they're working on the skill of gaining in the ability to present things in public, that would be another example of a gap in skills. I think that lack of communication skills is very often a gap in skills. And I just wrote an article for Pediatric News about children who threaten violence in school. And I actually had another child who was also had mild autism, who was suspended from school because he had threatened to kill the teacher. Well, the fact is, this child had no way of negotiating with the teacher about the homework assignment, and the only words he had available to himself to try to change what the teacher was doing in asking him to perform something he couldn't do, he chose the only words he had, which is, "I'm going to kill you, I hate you." And so being able to recognize that is really important. One of the things I talk about in that article is the lack of effectiveness of a zero-tolerance policy. And so now there is evidence that school programs which do a functional behavioral assessment for violent behaviors in school have much greater success, not only in reducing overall violence in school, but also in keeping children in the school and not having them get suspended. But Dr. Azil Mangai suggests that there in India, for flexibility, they teach the parent to persistently change the routine in a stepwise manner. And that's that's exactly what we're talking about here. And that is a form of experiment. And when the parents are engaged in thinking that they're sort of scientifically trying to figure out what works and to make those changes gradually, that really is a great approach to children who have inflexibility, no matter what the source of their inflexibility is, whether it be autism or something else. Thank you for that comment.
That's a kind of habituation that is an important element of these, that not just changing the circumstances, but it's actually changing the kid, and over time, and changing the expectations of the parent is part of that. Sometimes the total problem is the expectations of the parent,
right, or the school.
There's something in between, and then it also the pediatrician can help in the United States with these 504 plans to when they see that there's some limitation that you talked about, the anxious kid who doesn't want to talk, and maybe they can get an accommodation to not be called on unless they've agreed to it in advance, or all kinds of things like that.
Exactly. And a 504 plan is actually a legal right when there is a health condition that needs to be accommodated. And the most common one we're writing 504 plans for is ADHD, but it can be written for anxiety disorder or any other thing that has a diagnosis, simply with a letter from the doctor. So don't forget the power of the pen. That's something that doctors can do, whereas parents have to initiate IEP requests. Doctors can actually work with parents to come up with things that the parent thinks might be helpful for the school to try out.
I like the idea of gradually changing expectations, and one of the ways I see the most common one is this, as I mentioned earlier, transition problems, and being able to come up with a compromise and get the interpersonal conflicted part out of it by even having a gadget like a timer that goes off and goes bing, bing, bing. I'm increasingly liking a particular gadget that for these inattentive kids and autistic kids who have trouble with these transitions that has a light. And it goes green, yellow, red, and then it has warning, and then it has a noise. And so we've defined why they're having trouble, and then in the moment they get a little extra time they're not flexible about stopping now, but they could do it and agreed upon, 2 minutes or when it gets to the red light. Something like that is along the same lines of increasing or changing expectations.
Mm-hmm. So some obvious ones in school, other types of gaps in skills that may cause a child to act up behaviorally, besides what we mentioned in terms of some rigidity and some anxiety, and communication skills. Again, always communication skills is one of my top choices. But some children have trouble, for example, with written work and will act up to avoid written work or even tear up their work if they aren't able to control their pencil or pen well enough to be able to write. Obviously, you want to both help them bypass that by presenting their work in other ways. For example, in that case, might be orally or through artwork. But you also want to work on building up the skill. So it not to say that we don't ever want a child to be able to write functionally. But this is a kid who should be allowed to type, for example, their assignments, which has many benefits for kids. Other kinds of gaps in skills might be coming from, as we mentioned earlier, some intrapsychic causes. For example, a child may have trouble tolerating a certain sibling who they regard as getting preferential treatment. And so in that case, once you understand that perception, then the treatment plan for the family would include making sure that this child gets more individual attention and that things are talked about differently with regard to that sibling. So that begins to sound like regular behavior therapy, not functional behavioral assessment, but these things are very closely related. Do you have any other examples from what you do in India for this? Is the school open to functional behavioral assessments? Dr. Ezilmanga? Does the school institute things for children who have some special difficulty adapting to the classroom situation? Every school is equally open to this. So teachers have their own prejudice. So we've talked about prejudiced parents. Well, there's certainly prejudiced teachers as well. And some teachers are more rigid. Some teachers have an idea that ADHD is not a real condition. And so that they think if you just discipline the children more, that they will behave better. So Dr. Ezilmanga says, no, it's really difficult to get schools to understand functional behavioral assessments. So it sounds like the work is really to explain this to the parents and help the parents know how to work with their child gradually over time to improve their skill set.
And making some gradual accommodations isn't just for the child who also has a gap in skills, but the parent may have a gap in allowing flexibility. And then that's where that Ross Green's collaborative problem solving would take the gaps in skills, I would think, and say, before you institute your intervention, parent, like timeout or no, you can't ever do this in the future. We're going to lock up your video games, let's say, that they first pause and acknowledge their hypothesis or learn a little bit more why the child's upset. I see that you're really, really upset. You love that game, and you wanted to keep playing it on and on and on. I can see it. That was a Star Wars game, and you just love Skywalker and this and that. And as the teacher or the parent is acknowledging what the trigger might be, the child then is able to come down from their very aroused state and may even be able to regain enough logic to then engage in a problem solving. It's something that you can play with that video game. It's a great one, but we're going to have to leave the house now, and you can do it when we get back, or would you like to do it after supper or something like that. So they come to a stance pausing themselves, allowing greater flexibility in their interaction, and
not giving up on the parent.
Collaborating on a something that works, and so that's part of trying out things and also getting the parent and the child to get to a more a flexible way of interacting and solving these problems.
Right. Now, I think one of the other problems you see in families is often you have one parent in the room with the pediatrician, but there's another parent who has a completely different assessment of the situation. Often it's the father who says, you just aren't strict enough with him, is what the father is saying to the mother. And so it's important to find out who the other people are who are interacting with the child and may be perpetuating the behavior because they have a different assessment of what the source of the problem is and what the solutions might be. So even if you don't have that other parent in the room, it's really important to say who else, and that goes back to my slide about context, who else is interacting with the child in a way that brings out this problem, because the child may be very successful managing their behavior with one adult and not so successful with another adult. So I invite you to think about this some more and try it out. I see a comment here that that from Dr. Azilmangai, that it's very true about the disparity among parents. He sees that in India as well. And do you find it hard to work with parents when they're not present? Like, can you get the other parent to come in so that you can talk about their different point of view about it? That's hard in the United States. I do more and more partial cell phone visits. And I imagine there's cell phones there in India as well, where the partial cell phone visit is you get the other parent in on the phone. So I'm talking to one parent, but I've got the other parent on the phone. And frankly, even though it's a little bit more difficult than doing it in person, I have to say that it gives you an opportunity to actually talk directly to the other parent and get their point of view on things. It's kind of irreplaceable, actually. It's really been a huge benefit. So I don't hesitate to include other parents on cell phones during the visit.
Yeah, I can think of the last one. I had to tell the father, who was a truck driver, to pull over before he engaged in his part of the interaction. But it worked out fine.
Yeah.
Once he did.
Yeah. Right. So I think that the final thing I'd like to say about this is that children are very often, if you give them a chance and they feel like you're on their side, they're very often able to tell you what is causing the problem for them. And they may start out grouchy about it because they feel as though they're under fire and about to be disciplined, and often they've already been disciplined for exactly the behavior at hand. But if you say to them, we want to figure out how you can more comfortably make it through the school day, what's going on for you, what is it you're thinking that we need to change, what ideas do you have about what might work better, they may say, well, if this stupid teacher would just throw all of those pens in the trash can. And that might be the child's way of saying, oh, I can't use a pen. And so even though they may not have a good way of talking about it, if you're a careful listener, you can often figure some of this out with the child themselves. Well, thank you very much for joining us. This call has been recorded, and we will put it up on the Chattis website, where you can find all of the other webinars that have been recorded from our case conferences. Just go to the For Clinicians section of Chattis.com, and you will see case conference recordings. And right now, we're not able to give CME credit for looking at those recordings. We're hoping to do that in the future. But if the person at 8822 would like CME credit, what you need to do here in the United States to get CME credit is to send a message to bhoward@chattis.com telling me 2 things that you will do differently or think differently about as a result of this session. So please join us again in the future for these case conferences. I assume that you're getting the notices about it, and if you have cases that you'd like to present, if you're presenting from India, you can send me a case, which I can read if you'd like that. But otherwise, we'll welcome you to be audio on the call. So take care, everybody, and happy holidays.